Thank you very much, Terry, for moderating, and to you, Sherry and Margaret. That was truly wonderful. And we have Paul back up here to share with us some reflections of the day and help us wrap up. Are you all set? All right, thank you very much. Take it away, Paul.
Well, thank you. It's been a very educational day, interesting day, stimulating day. I hope you found it that way. I'm going to kind of give my top 10 list, so to speak, of themes, doing it through a collaboration lens in particular, because that's my expertise. But I want to do that in just a few minutes, and then ask you to offer what you would see as some primary takeaways, some practical things that you would do next, that you would actually take ideas from today and what would be one concrete, tangible thing that you would take to your organization, to a committee, to a network, or whatever. And I'm not going to ask for a show of hands. I'm just going to walk right up to you with the microphone and get it done, because we do want to get out of here and we want a lot of stimulating ideas. So if you don't want to be confronted, leave now. So here's things that I heard. Here's things that I heard today. One, first of all, acknowledging the basics. Collaboration is essential. It's essential because the issues we're facing are complex. It's essential because health is not influenced totally by health care. There are a variety of other things in the environment, social, political, economic, that are important to understand and to reconcile, and therefore that health care and public health need to collaborate in addition to other systems collaborating with them. A health in all policies approach inherently requires collaboration. In Minnesota, our Commissioner of Health, for example, in doing health in all policies, goes and meets with the Commissioner of Transportation, the Commissioner of the Department of Natural Resources, and says, what are you doing about health? You can't get that stuff done without collaboration. And then, as we heard in the asthma example, of course, practical issues, linguistic issues. You can't get to certain communities unless you pull in different organizations who can work with those communities. Or there's a need to approach various diseases that all intersect within a community through collaborative action of organizations that are addressing each of those, as Lloyd mentioned, in order to get resources, to get funding. Two, I think we have success to build on with respect to that collaboration. We saw it today. Maybe we're a toddler, right? But at least we're not, or we've been born, and at least we're not in infancy. We're starting to move ahead, make some progress. It's exciting, as Sani said, that the progress is not just with respect to the service integration side and collaboration, but even the payment side, which might seem more complex or more mundane, or however you would see it. So it's been exciting to see today these examples with respect to payment reform, the Million Hearts campaign, hospital public health collaboration, and asthma, to see that that work is going on. It's not just in its infancy, it's moving ahead, and also to see that the research is going on, as Larry and his team are doing, and making progress with that in order to develop an evidence base that struck me. Three, the fact that the success is being reinforced, at least in principle, by leaders. HHS was mentioned, others at the federal level, healthcare leaders, a number of foundations who are being innovative, academic leaders. Even if actual action and funding is lagging in some of these spheres, at least the endorsement for this collaboration is occurring. Four, the importance of leadership in this. The Ohio example, from the governor down to local level, and how critical that was for success. The Million Hearts campaign, the empirical basis that Larry and Nicole and Sunny were talking about, which demonstrated the critical ingredient of leadership across the partnerships that they explored and are monitoring. Five, the importance of metrics. Larry, Mary, Ted, Joe, Gus all mentioned this. Metrics to understand impact. And often brought it up with respect to challenges. Challenges related to internal metrics concerning patients. Sometimes the data don't exist that we need operationally, strategically, to plan for collaboration and to monitor the success of collaboration, or sometimes those data are hard to access. But a frequently mentioned theme today was that EHR systems are designed for claims. They're not designed to do the work that many of us want to do. And we have to overcome that if we're going to make some progress. External community data, likewise, sometimes difficult to come by, not always available at the appropriate level for analysis. But there were many hopeful indications in some of the presentations as well. The fact that the process of joint measurement, as Nicole mentioned it, actually led to the building of relationships among collaborators, or the great example of asthma, where on the front end, the community needs assessment and the various mapping techniques are targeting the places where the need is the greatest and where they need to focus services, and then the measurement of outcomes, ED visits, admissions, costs, and so forth that are being monitored to see whether the collaborative initiative is really having any effects. Related to this, maybe we don't want to hear it, but I am going to repeat something that's Ron brought it up, but it was kind of conspicuous by its absence, the elephants in the room, the negatives. One of the issues that we do face in moving forward is that the research rarely reports the failures, rarely reports the negatives. We've been looking at case studies for 30 years, and it's very difficult to find failures in the literature. They don't get published in journals. People don't actively finish reports about the failures. And this is difficult. I mean, imagine if hospitals only touted the patients who were cured and never did an autopsy. Where would we be? And so if we don't at least look at some extent at where collaboration is failing, we will be somewhat impeded in the process of discovering all that's necessary to make it effective. I participated in a conference about a year ago that was by people who are reforming educational systems, and actually one of the sessions was a competitive session where they gave some small rewards to the speakers who were finally picked for the panel, or they gave their organization some money or something. And the focus of the panel was who failed the worst. That's what you had to propose and describe and explain why the failure occurred. Might be something that we would want to consider in order to advance the state of the field. 7, the importance of clear goals, commonly accepted and understood, to provide focus and orientation, was mentioned a number of times. 8, implementation. Don't just plan, but implement. Mary Applegate said this, and it reminded me of that book of many years ago, In Pursuit of Excellence. And remember, one of the characteristics was a bias towards action. That if we have a propensity to act and not just to talk and plan, we will be more effective. Things will never be perfect. We have to move ahead when things are good enough. Select a few priorities, not 64. Get people to focus on a small number. Build, have a snowball effect, create momentum, and change will occur. 9, the importance of understanding multiple layers. It's just a fact of life. Mary and Ted mentioned this for Ohio. Gus, Joe, and Paul mentioned it for the Million Hearts. Understanding that across systems, we have to involve various levels to be effective. Within organizations, we have to involve all the levels of management and operations. And the asthma example, again, was a perfect one in terms of the city level, the agency level, the community level, a variety of levels who had to be engaged in order for success to occur. 10, innovation occurs naturally in unexpected and sometimes serendipitous ways. Librarians for blood pressure, protocols for referrals by barbershops. Those kind of things that you would have never thought of at the beginning and maybe never predicted, but just occur because people are entrepreneurial, people are creative, and once you get collaboration going, those kind of good ideas come up. I actually had 12, not top 10. Number 11 is the importance of building relationships and building on relationships. Sonny's What's in It for Me, not in a selfish way, but remember, the people and the systems we're talking about are extremely busy. And collaboration, no matter what, takes more effort up front. Okay? It's not a time saver. It may be a time saver eventually. It may increase effectiveness and efficiency, or it might not. Things might even off. But at the beginning, I can guarantee it's never a time saver. So what are you going to, in order to get busy people to be motivated to do this, they have to see how it's in their interest. That's a very rational question. In order to get the kind of engagement and relationships that are necessary, language issues will have to be overcome. A number of the speakers and panelists said that today. That includes the languages of the disciplines, the languages of the communities, the languages of patients. During the question and answer period, Lynn asked, well, or suggested that what patients and communities want should be what we base our decisions on, not what we think that they want. Well, to get that, we have to talk to those different communities, talk to professionals across disciplines, and so forth. And there are formal ways to do this. For example, community needs assessments, as we saw in several of the panels today, but also just ongoing conversations. And then finally, number 12, I think Larry said this well, reaching out to other systems, schools, housing, employers. This theme came across in a number of the remarks of the panelists today. In order to create a culture of health, it's going to be necessary to reach out to all of those systems because healthcare, public health, can't do it alone. They need to collaborate, but they need to work with other collaborators. And the quote from Saint-Exupéry, that when we engage those other providers, it shouldn't be to collect wood to build boats. It shouldn't be just to give them tasks and assignments where they don't understand the whole, but it should be to enable them or to prompt them, to stimulate them to long for the endless immensity of the sea. And that immensity of the sea is building a culture of health, that they can understand where they fit into that and how collaboration can effectively get everyone to do their part in order to build that culture of health. So with that, I hope you've thought about your assignment, because I'm going to come out with the microphone, and the question is, what is a takeaway from today that you are going to go back to your organization, to your community, to your network, your professional group, whatever it might be, and you have like 15 seconds. So what is it, Margaret?
I think for us, the payment issue is still really complicated, and there are other communities that were represented here that are far more advanced in those conversations than we are.
So you'll follow up on that and try to bring that.
Hi, I am an IOM staffer, and the group that I work with is a Roundtable on Obesity Solutions. So I think my takeaway for our group is the synergy between the work that folks in this room are doing and ours doing is greater than we expected and than we know.
Okay, thank you. Kathy.
I think one of my takeaways is we're not where we were 3 years ago or 6 months ago, that even those things that we thought were the reality at some point, we have to recognize that that reality is changing and moving as we speak. So recognize that even when we think we're moving, so are others. And we need to keep reaching back out to people and expecting that things can have changed.
Okay, thanks. A few more concrete, tangible suggestions of what you might do when you get back to wherever you're going?
I can't say anything tangible. It was a very enlightening day, and I learned a lot. I still think that there's a very large medical model that permeates the discussions we had today, and the sort of social determinants of health seem not to be really at the interface of the medical care system and the public health system just yet.
Monica?
I think as it relates to the work that we do at ASTHA with our Primary Care Public Health Collaborative, really looking back at that slide and that list of partners that Paul showed and figuring out who's not part of the collaborative and how we can work with them.
Thanks.
Hello, Sharon, and I'm also from ASTO, and what I would say is we really want to continue our work with Larry Pryble, his excellent report, and really actually use that as a way to measure our current collaborative and where are the successes, but also where are the failures and where can we improve our quality.
Thanks. Looking away from me won't save you.
I tried. I guess I'm still intrigued by this notion of we're still largely public health and healthcare people in the room. And how do we actually engage people from these other sectors in a meaningful way and engage them in it? And I don't think anybody really knows that. I'd love to know of an example of successful collaboration that really did bring in all these other sectors.
So finding that actual example would be helpful to bring to your networks and here. Okay. Jessica?
Well, I'm not a practitioner. I'm someone who researches what didn't work when it comes to public health collaboration. So for me, the takeaway is that I've seen some case studies of things that have worked. And so it'll lend credence to the philosophy that I'm trying to push through in my research.
Thanks. Anybody else want to say something?
Hi, Pamela Russo from the Robert Johnson Foundation. Like Martha, I heard about a million things I'll take back.
Just one.
All right. The Ohio story was very informative. These are complex problems. They require complex solutions, but if you can break them down, you might make progress.
Okay. Volunteers. 15 seconds.
Omission, we didn't talk about dentistry and oral health. Tremendous omission of the day. You didn't ask for that, but I wanted to say it.
That's an elephant. Yeah.
And then takeaways, before I go home, I think we need to think about the implications for our metrics and our networking workshop. And then I think we need to think about the implications of this discussion for follow-up discussions here.
Great. Terry?
What's the thing that stuck with me was what Larry said about being very positive about what he's seeing. He's seeing a real change. I think that's motivating. He's seen a change in the relationships and the level of engagement. And I think population health concept is gaining steam, and we're seeing real change in the system, so I'm motivated.
Okay. More volunteers. And then we're going to, okay. George?
From the California Endowment, we do deep work with communities, and we've learned that you need to involve communities. You can't, it's important but not sufficient to talk to communities. You have to involve them in decision making, and that's a big difference from simply receiving input on a survey. And that means that you're going to have to listen that a blood pressure pill may not be the solution, and it may not be success. It might be how many people from this community graduate from college will get you closer to health.
So formal assessments plus community conversations, and who defines what the information means. You need to look at community perspective as well. I think there were two more over here.
I promised Larry Preibel that I would help the acceleration by sending his report to the 2,000 United Ways in the USA.
Whoa. Now that's very concrete.
I think the concept of certificate of need needs to be expanded in ways that bridge medical care and public health. And I think that agencies like HRSA could provide information in the way they identify shortage areas, healthcare resource shortage areas, and that those would be levers for accountability to implement some of the ideas that were discussed today.
Okay, thanks. David's in the wings, and thanks very much.